Welcome to AUA Leadership in Business, an official podcast of the American Urological Association.
Welcome to the AUA Leadership and Business Podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I am Dr. Micheal Darson, and in today's episode, we will discuss hospital-employed versus private practice perspectives. Joining me today for this discussion is Dr. Fabrizio, Professor of Urology, Eastern Virginia Medical School, and past President, CEO of Urology Virginia. He has been on the LUGPA board for 6 years and was past president of the Mid-Atlantic section of the AUA. His group is 100 years old, and the AUA just celebrated that last year. And for 3 years and 10 months, they were employed by Centara Healthcare. They also have evaluated private equity and MSO, or Management Service Organization, models. Dr. Fabrizio, welcome.
Thank you, Michael. It's great to be here. Thanks for inviting me.
Well, let's go ahead and get started. I'm very curious to learn about the history of your group.
So our group is really a historical group. The AUA just celebrated it last year. As you said, it's 100 years old. The Divine family really spearheaded the group many, many years ago. They were sort of the leaders and founders of genitourinary reconstruction. And between plastic surgery and urology, they created this specialty. And the group has a long history of having that legacy, continued up through Jerry Jordan and others who, Kurt McCammon, Steve Schlossberg, who really continued that legacy. And then the group has grown significantly. In the 60s, developed a residency program. They were a private practice group with a residency program. And then in the early 70s, the medical school was founded, Eastern Virginia Medical School, and we were folded into the full-time faculty. So we're a private practice, but we're a full-time faculty with residents and fellows. We've had residents in genitourinary reconstruction and residents in endourology. And in 1997, Steve Schlossberg thought it would be good to take the 7 or 8 of the core academic faculty and merge with the private practice groups around the area and create a big group, economies of scale. And that happened in 97, 98. I subsequently joined in 99. And then we grew to be a pretty significant group of about 35 urologists. And then in 2008, we joined a health system, Centara, as you noted. We left that relationship in 2011, and I'm sure we'll talk about that. But and then we reformed our group back in 2011 as a private group. All of us exited Centara that went into Centara, and that's where we are. We became a big LUGPA group, part of the LUGPA organization. And as you mentioned, I was on the board for 6 years. And that's sort of the history. It's a unique history in the fact that we've sort of spanned all gamuts of practice in a way. So.
Yeah, that's quite a history. So it was in the 60s that you started having residents?
Yes. In the mid 60s, they started training a urological resident. And then that program really grew under Paul Shellhammer, our partner, and Jerry Jordan. They really expanded the program. We became 2 residents a year in the 90s and have subsequently grown since then. We train a Navy resident every year and a private an AU resident through the AUA match every year, and we're looking to expand our program to 3 now.
That's interesting. So prior to the medical school, where did the residents come from?
So prior to the medical school, they were, I guess the match process wasn't quite the same as it is now. So I think the applicants knew that there was a program here at Eastern Virginia Medical School and applied for the program and interviewed just like they do now. And they were accepted for a program. We had several of our partners, Gil Masquera, Joe Conifal, some other partners who trained under that program.
So interestingly enough, it sounds like a pretty cool evolution of the residency. How did you come about the relationship with the Navy?
So that relationship basically spawned because we had several partners who had had careers in the Navy. Jerry Jordan, Don Lynch, and there was a good relationship with Portsmouth Naval Hospital. So there were, I think, effectively three training programs in the United States: Bethesda, our program here with Portsmouth Naval, and San Diego for training Navy residents. And we now have, I guess, two programs, which are San Diego and our program for training the Navy residents.
And those residents, they come through the Armed Forces Scholarship Program.
That's correct.
Yeah,
Yes,
that's an awesome program.
it is.
I got some exposure to that when I was in medical school. I went to medical school at Wright State and did rotations at the Air Force Base there. And those, I remember thinking that those were some really sharp individuals.
They are. It's been really rewarding to do that, and we still have great relationships with many of them.
That's awesome. Tell the listeners about what drew you to the group.
What was really the draw for me to the group was having great names in this practice, like Paul Shellhammer and Jerry Jordan, who were, behemoths in the urological community. It was a great group with a great reputation. It had a residency, which I was very interested in. And it also happened to be the locale where my wife is from. So those combination of things really drew me to the practice. It's a great location. We're at the mouth of Chesapeake Bay, right on the ocean. We cover a large geographic area, and we have a great deal of patients. The population is immense, and at the time, I was starting laparoscopic surgery, and there was really not a lot of laparoscopic and robotic surgery going on, so we could start the program here. We were in the FDA trials for robotics. So there was a lot of opportunity for growth.
Yeah, that sounds like a fantastic decision. Where did you come from?
Right. So I did my residency at Thomas Jefferson University with Demetrius Bagley and Grant Mahalan, Lenny Gamella, and the whole crew at Jefferson. And then I did my fellowship at Johns Hopkins with Lou Cavusi and Tom Jarrett. Joel Nelson was there, Bud Burnett. So it was just a great group of people that I got to work with on a daily basis. Of course, Pat Walsh and the entire team, Alan Parton, and so it was a great place to be.
So, did you join the group right out of residency?
Right out of fellowship.
Yeah, that's awesome. It must be a good group if you're still there.
It is.
There's
It's really interesting in our group up until recently, and Beverly will talk about that in a minute. But we really had no exodus from our group. Everybody came here and stayed here. We had nearly a 100% hire rate and retention rate for many years, up until just till the last couple years. That was the case. So once you came, nobody left.
Yeah,
and it wasn't like the firm, but it was much.
For the residents and fellows that are listening to that, that is such a critical piece of information that you really want to vet out of practices that you're looking to join. One of the key red flags is a lot of turnover.
Agree.
And a group that has none is rare and something that you take a look at.
Yeah, we really pride ourselves in that. We've had some folks retire recently, and we had a few younger ones just in the last year and a half that left for personal reasons. Wife got a job in another specialty as a vice chairman, and family issues. So there was, but other than that, we've rarely had anybody leave in our practice.
Well, let's talk about the relationship you had with Centara. That sounds pretty interesting.
Yeah, it's so. That relationship was a really interesting relationship. In 2007, Steve Schlossberg was chair of health policy for the AUA, and felt that there were significant changes affront in healthcare, and indeed, he was right. There were a lot of changes. I think he felt he was the managing partner at the time. I took over after Steve for 12 years. And then, of course, Jennifer took over after me, Miles Thomas, but for 3 years. So we had he had a thought process that because everything was being consolidated, hospital-based care would probably be, and hospital-owned care would probably be the wave of the future. He felt that the government was sort of moving in that direction, that legislation was going to favor hospital systems, and indeed that was the case. And he also felt that being a private practitioner was going to be difficult. I think he was probably 5 or 10 years ahead of his time in that respect. I think now, we're seeing some of the difficulties in private practice. We'll talk about that, but based on that, and Sentara is a great system with respect to its national reputation. They're a nonprofit health system, like many are, but are significantly profitable. They have billions of dollars in the bank. So we felt that we could use their considerable resources to help grow our footprint and bring a lot of resources that may be difficult in a purely private practice group. And we already had a significant relationship with them and doing a lot of programs. Like I said, the FDA trials for the robot, they signed off on. They had to buy the original, robot to do the FDA trials. And they were very supportive of a lot of the technological things, rounding robots, telesurgery, things that I was very interested in, as well as our reconstructive program. They supported. So, and they also help support the residency program. So we already had a relationship, and we felt that we could sort of augment that relationship by being an employed model and maybe relieving us of some of the administrative headaches of private practice.
That so how did that relationship evolve, and why did you ultimately?
Yeah, so what's interesting is that I think it was maybe a little too early in its time frame for each of us, and I think what happened was that they viewed us as sort of a budget item in a very large budget, and not necessarily a program. So I think there was different expectations for both parties coming into the relationship, and I think that those set of expectations probably were the beginning of the end of the demise of the relationship. Uh, it was difficult to sort of get your seat at the table with respect to budgetary issues, and um, and there were a variety of other things with respect to the way that we wanted to grow the business and expand the business that maybe ran, um, you know, a little bit different path than what Centera was usually taking. Um, so I think those misaligned goals really created some anxiety with both parties. So we felt that maybe long term, for preservation of our group and our the long history of our group, not changing the culture of our group, which we certainly would have had to do in a hospital employed model, we felt that it was important for us to maybe think about exiting. Of course, that evolution took a couple years to really start getting to that point, but we did have an exit clause that, and it was, I think, to Centera's credit, that if 75% of us thought that this wasn't working out, we could reestablish our own group. We couldn't go, to different groups in the area or other hospital systems, but we could reestablish our own group. And that was an important aspect of our contractual negotiations. So, um, and I think hospital systems um, in general, are very focused on revenue growth. There are some different laws that actually affect hospital systems and not private practice groups. So you have provider-based billing, which maybe some don't know on this podcast, but provider-based billing is where a hospital system can bill for the E&M code that the physician charges, or the surgical code that the physician charges, but also they can bill a facility fee for a lot of the different things they do, even office visits. So if they own the office that the physician goes to, they can potentially bill an additional facility fee for that. And same with imaging and other things. So, they're focused on that. Sometimes that is not a positive, as you've heard about in the news, where they can raise the cost of care for seeing a patient, and that's an issue. So there are some things that you have to think about when you join a health system, especially as a previous private practice group, for the patients, because it does change the actual care for the patients and the cost of that care.
Well, in that relationship, I mean, I would think that the number one piece of advice that I would give is make sure you have that exit clause.
Yes. Yes, that's incredibly important. The exit clause was probably the thing that saved us both. And actually, we still have a very good relationship with Centera Healthcare. We cover all of their facilities. We have a practice management agreement to do so. We work well with them. They have a very robust cancer program, and that's also helped run by another private group, Virginia Oncology, in our area. So we work very well with them, and as I said, they support our residents and our reconstructive program. So there was a lot of tension on the exit, we were able to salvage that relationship and really not have any adverse sequelae for either party. So I think it's a testament that you can actually have these relationships, and if they don't work out, you can still maintain a positive working relationship. Um,
Yeah, it sounds
but
like
certainly, go ahead.
I was going to say, it sounds like mutual respect is a key component to being able to survive the exit and maintain a good relationship.
Yeah, absolutely. And the reality is physicians, there's animosity nationwide on hospital employed models or academic models versus private practice. I think when you and I were training, and we trained, I think almost at the same time, this was recently in a Becker's article, ASC model, that you had physicians who decided to leave, complete their residency program and go into private practice. They were almost selling out. You're going into private practice. That was sort of the thought process when you and I were coming on board.
Right.
I think now I think that philosophy's changed a little bit, and I think there's some great synergies that private groups offer. There's some with the academic and hospital employed models, and I can think of a few like research and patient navigation for disease states, and I think clinical trials. There's a variety of different things that private groups can offer with some synergy to the academic groups. So, and I think they can be quite academic. I mean, you can have groups like ours that are publishing and have fellows and residents, and still be a private group. It's not common, but those do exist. Um, but we have seen a pretty significant exodus nationally from private practice groups. So 10 or 15% of physicians over the last 10 years have now gone to an employed model. And more physicians are actually employed by an entity such as hospitals or academic settings or multi-specialty groups than are actually in a private practice group at this point. And I think the jury's still out on whether that's a good thing or a bad thing. And of course, now in our specialty, like many others, you've seen the acquisition of groups through private equity. Private equity ownership is transient. There's no debate in that. A private equity group is not going to own a group for more than 5 or 6 years. Maybe 7 or 8 if things are slow. But most private equity groups, exit their relationship and go to and get acquired by another one. And I'm not sure that I think the jury's still out on what that's going to do to healthcare. One thing that it's definitely doing to healthcare is it's decreasing the manpower in a more rapid fashion than was historically. That's one of the many reasons that we're seeing a drop in the number of physicians in the United States. And I think that's also one of the reasons we're seeing difficulty with access is that physicians are retiring. Private equity with physicians getting payouts and those type of things allow them to retire probably a little earlier than they would. That's one small piece of that equation, but I think that's we'll have to see how it all plays out in the next 5 to 10 years.
Yeah, I think the next 5 years is going to be really interesting to see, especially in urology, how this plays out. I think we've got some indicators from some of the other specialties that there's some good outcomes and some not so good outcomes for sure.
Agreed. Yes.
So just for our listeners, and I know this is always an interesting thing to think about. Can you talk about not-for-profit organizations that have a lot of money?
Mm-hmm. That's great. Yeah, well, one of the reasons we joined a health system is the overhead expense for us is rising just like everybody. The Medicare cuts are hurting us with respect to being able to reimburse our physicians for a competitive salary. So we thought, as I said earlier, going to a health system that has $5 or $6 billion in assets in the bank would be able to help with that. So and this is a generic statement, not with Centera or any other health system, but the fact that so many hospital systems are non-for-profit and they have such large coffers of cash, I think really flies in the face of what we're trying to do in healthcare. So that means that they've made a lot of money. Health systems make a lot of money. Provider-based billing alone, where when they see a private practitioner, hospital the patients go to just see a private practitioner, they get an E&M charge, of office visit bill of say $180. But many health systems around the country now provide that facility fee for seeing the doctor. So that same doctor now gets employed by the hospital. They still have the $180 patient visit, but now the hospital system is giving them a $220 bill for the facility fee, or a $200 bill for the facility fee. And that patient, if they don't have a secondary in their Medicare, they are responsible for 20% of that copay. So now that visit can cost $500 or $450, and a lot of systems are doing that, and that also applies to their imaging and other things. So I have significant problems with the nonprofit status of many health systems because they have such large cash holds. If you look at many of the top 10 health systems in the United States, they have more assets on hand than the top 20 Fortune 500 companies in cash. So those are health systems. Think about that for a second. And the other thing is that health systems have significant venture capital funds. So Providence Health System out in the West has $1 billion for their venture capital fund. University of Pittsburgh has made hundreds and hundreds of millions of dollars on investments, like every other health system, on their venture capital funds, where they deploy cash into startup companies that go public or get sold and make a lot of money. So they also have this great investment vehicle that they don't pay profits on when they actually win. And the amazing thing is that the health systems don't pay state, federal, or local taxes on any of their assets. So that is really difficult for a private group who's struggling along with 4 urologists maybe, and have to pay assets on their computer forever, even though the computer is worthless, or the table, and the health systems don't do it. So really, I think that whole system needs to be revised. And I think we need significant legislation to say, at some level, if you make enough money, you're no longer a non-for-profit health system. And return and also you don't see really the return on that cash in communities from the health systems as much as you probably should. So I feel pretty strongly about that.
Yeah, and I think that's a disconnect for most people that haven't somewhat of an understanding. It seems that the nonprofit status is a tax vehicle.
Yes.
Yeah.
Yes. So. Now, some systems, in full disclosure, would not survive without that. So your very rural health systems, and I will agree to that. So rural health systems where you need a facility, if they didn't have a nonprofit status, they probably wouldn't survive. So let's not make it all bad. But what I will tell you is that the American Hospital Association is the strongest lobbying force in Congress, and you and I have both been in Congress lobbying. And I will tell you, when you present this information, most congressmen and senators will say, "I have a hospital there's a hospital in every district in the United States, and they are one or the number one or number two or number three largest employer." So they have significant power, and they're reticent to create legislation against that, and we saw that with the Affordable Care Act, and we were told that the hospital systems were sort of off the table with that, with respect to any draconian cuts or measures.
Yeah, well, if you have a powerful lobby,
that's it, right? But
we talked a little bit or some about the hospital employed model. What were you talked about some of the advantages, and you talked a little bit about the disadvantages. What advice would you give to a group that is considering a relationship with the healthcare system?
So it's a great question. When you're looking at joining a healthcare system, you first of all want to see what kind of synergies you already have. I think that's important, and hopefully you have a few that exist. And then you want to use the contract to expand on those synergies. So if it's growth, if it's developing ancillary revenue streams, if it's providing new services, those are things you want to craft in the contract. You also want to make sure that you get the administrative support, because that's really one of the big things that the hospital systems can offer, is that they have layers of administration that can actually do your budgets, market for you, help implement ancillary components of your practice, such as in-office dispensaries or PET scanning, potentially radiation therapy, those type of things. You really want to make sure that your contract describes in detail how you're going to integrate those things. I think that that's incredibly important. And you also want to make sure that you do have, as we mentioned and alluded to, a good exit clause if it doesn't work out. You want to make sure that there's some sort of symbiotic exit if it doesn't work out, because when you do sell your practice, you're going to be there for a little while. You can't just leave the next year or two. It's too financially expensive for both the practice and the hospital system. So those would be sort of my advice. I think, the other thing that we haven't discussed is recruiting. The hospital system will provide a great ability to recruit. They have a recruiting staff, and they can offer more money than can be offered in necessarily a private practice group oftentimes for starting physicians. And they can do that through a variety of revenue producing activities, some of which we've alluded to in this podcast. So I think that that is some of the advantages. You want to make sure that you have the ability to recruit on an annual basis, and that you don't want to have that limited, because that also will hurt you. So you have to make sure the contract is pretty tight.
Well, it sounds like the beginning point is any group considering it really has to understand their own strengths and weaknesses to be able to develop those synergies and then have them spelled out contractually.
Yes.
Can you talk a little bit about how you would work with the healthcare system to develop those ancillary streams? And can you tell us a little bit about how that works contractually?
Yes. So you a lot of meetings. There's layers of meetings to do this, but let's look at a program like specialty pharmacy. So in-office dispensary. So it's the same thing. If it's a private practice group, in some states you have to call it an in-office dispensary. If it's a hospital, it's a specialty pharmacy. So if you wanted to say, we want to manage our advanced prostate cancer patients and even potentially our advanced bladder cancer and renal cell patients within the practice and develop a service line to do so, you can work with that hospital system to contract or potentially employ a medical oncologist and create a navigation team so they can navigate patients using data and actually build a significant revenue stream for delivering advanced drug therapeutics to these patients. You can do the same with radiation services, a variety of different radiation services, creating an SBRT program, for instance. That is a unique service line. And then finally, PET imaging, another thing that just pops in, doing PET image and potentially theragnostic therapy based on the findings. Those type of programs can be built. The tricky part is that you can't necessarily, you're not going to get compensated for referrals to those programs. Obviously, that's illegal. But you can get compensated for the committee work doing it and for the time potentially invested in that. And that's really how you would sort of jointly create these programs. Additionally, the more programs you create, hopefully the more professional staff you need to hire, physicians and advanced practice providers. So you can work in synergy with them doing that. And if you're really productive, a lot of this does include productivity. A lot of hospital systems use the WRVU method to compensate. So a lot of these things do generate RVUs and will potentially result in higher compensation for you ultimately for doing the work, for these programs. So that's really how I think you would work in synergy. And so
Can you,
that's a little different than private practice, where you're actually spending the time to do it. You're taking away your time from practice, and you're not getting compensated for that time. You probably are getting compensated for that time in a health system. And then when you're in a private practice, that revenue that flows into the group, is divided equally. Typically, that's the best way to do that from a compliance standpoint. And so, it's a little bit different.
yeah, I was just gonna, I mean, you kind of answered my next question, but can you give us just like maybe a global view of how the compensation would work if you were developing this program in purely private practice versus what has to be done in a healthcare system?
Yeah, that's a great question. So a lot of these programs, at least in a private practice setting, when you start building them, cost the practice money, because you're getting the infrastructure, the data analytics programs on board. You're hiring, let's say, patient navigation staff to navigate patients through their disease states. But hopefully, if you build a correct program, and combine it with advanced practice providers, and you can see more patients, and you can build ancillary revenue streams by your in-office dispensary, by bringing in PET imaging into the practice, and hopefully you can then aggregately grow your revenue. So at the end of the day, will have more to distribute to the providers and the staff as potential bonuses. But that takes a lot of work. In the hospital-based system, your compensation is usually set at least at a base, and as long as you maintain a certain, usually low level of RVUs, and then anything above that in RVU production will increase your salary. And then you may get paid additionally for being on certain clinical committees. And so you really don't have the downtime issues when you're trying to build these programs, because you're actually getting compensated for doing those committee meetings. And remember, the hospitals are actually getting significant more reimbursement for everything you do. So whether it's a surgical procedure or a CT scan or an ultrasound, or even obviously the visit, they're getting paid significantly more per episodic care and episode of care, and they can actually hopefully afford to pay you a higher salary as a result of that. So that's sort of the difference between I think the two systems.
Yeah,
But you
it's really,
also don't have as much control in the hospital system. So you may get overridden by the needs of the health system compared to the private practice group, where it's your own group and you're controlling its destiny, and you decide what's important. So there is a difference there in that independence.
yeah, I think what you've just illustrated is it's incredibly important for physicians to understand the flow of money in a urology practice downstream, to really understand their worth. Because I think that's one of the things that leads to an unhappy relationship, is when doctors don't understand that at the beginning and they learn about it as it goes, and then they're like, well, I'm not getting paid what I'm really worth. And it's, I think it's in everybody's best interest if they try to understand that at the beginning.
Yeah, and I think you have to do your due diligence when you're doing these contracts for either your private group or your hospital employed group. You really need to look at the benchmarks, and there are some benchmarks that are utilized. I probably won't mention them here, just to be safe, but there are some benchmarks, and they're big name benchmarks. And for the Mid Atlantic region, for example, they only had 70 or 80 urologists participate in the survey. So, that's a pretty biased survey if you only have 70 or 80 urologists in the Mid Atlantic participating in salary surveys and other things. So, yeah, I think it's important for organizations like the American Urological Association to do their annual census and to get that data and really be granular in the data. And hopefully all of us participate in
Yeah, couldn't agree more. Let's drill down a little bit more on private practice. What is your definition of private practice?
that. Great question. My definition has probably morphed over the last few years. And so I am now, I'm a purist now. I still think private practice is a group that is owned by its physicians. whether it's one physician or 30 physicians. It is a group that is entirely owned, and the equity component is controlled by the physicians exclusively. Um, they have the ultimate control, they have the ultimate say. That is a true private practice group. Um, I think we're now blurring the lines in the definition when you look at management service organizations taking 15 to 30% ownership in a group. When you look at private equity buying groups, paying money for them, taking requiring the physicians to take a scrape in their compensation, rolling the a portion of that money back into the shares of the new private equity entity, and ultimately, the private equity hires an administrative level above the practices to control and to guide and to manage those groups. I'm not sure that's private practice anymore. I don't think it is. The physician, the individual physicians, and the group, the singular group, doesn't have ultimately the command and control that it did. So I'm not sure that meets the definition of private practice. I would the same with management service organizations. Um, I don't think that meets the definition. There are some interesting models, the PSA, the practice service arrangement, or the practice management agreements that hospitals can sign with groups. The groups maintain their independence, but they may provide some compensation for new people coming into their area, and they can do that legally for a couple years. That's still independence. But I think independence is the definition that I mentioned first, is that being able to control themselves.
Yeah, I think that that is a very clear definition, and I think that that's what most people think of when they think of private practice. And there is certainly a big difference between private equity and a purely private practice. The MSO relationship is kind of almost like a hybrid, in my opinion.
Yes, yes. But there are some joint decisions that have to be made in the MSO as well, where the physician group may not have the ultimate say in that relationship as well. So, but it may be a hybrid. It's a gradual process, as you said, from going purely private practice to some other entity.
Give our listeners an opinion on what are the top 3 challenges for private practice today?
Oh, that great question. And you'll get some differing opinions, but I think number one is the overhead expense. Number one, overall, is the cost of running a practice now is well above 65%. If you're running a practice that provides lots of services, such as advanced practice providers, navigation systems, data analytics, and those type of things. And so the overhead expense is significant. We now need compliance officers to make sure that we're trying to do everything as correctly as possible. And even when you have them, the amount of uh, um, regulatory environment, but not only just the regulatory environment, but the vendors that work with you, et cetera. You have to be cognizant of all of that in a group to make sure that you don't run amok of any laws. So you need compliance officers, you need HR directors, you need CFO and comptroller to manage books. You need lots of managers, nursing managers to control, to really run the staff correctly. And so the overhead has gone up, and the big issue is that, as we know, post COVID, about 23% increased salaries we're seeing across the board. So that's number one. I think number two is the compensation, how to compensate private groups and private practitioners commensurate to hospital employed models. It's getting more and more difficult. And the reason for that is the significant cuts in Medicare that have occurred across the board, which is probably the third issue. We've seen pretty significant cuts over the last 10 years in reimbursement. I utilize the example in our marketplace for a robotic radical prostatectomy. And so we get paid a little over $900 to do a robotic radical prostatectomy from our regional Medicare provider. And that includes taking care of the patient for the next 90 days. And that's fine. We love to take care of our patients. We love, I personally love that operation. But it's difficult when people hear that you get $950 for a 3 hour operation that is, technically, very difficult, has required a lot of skill, and that's what you get to take care of the patient for the next 90 days. It's difficult. And you're seeing that across the board, from everything we do. So I think that, those are the challenges that I see.
So let's take robotic prostatectomy, because that's a great example. Do you remember when you first started doing them, what you got reimbursed?
It was about 3,000, 2,600, something in that range. And certainly our private payers were even more in some cases. And they've eliminated that as well. So it's been a pretty significant hit in the reimbursement for those procedures. Same with laparoscopic nephrectomy and a lot of the endourological procedures that I do.
The reason I ask that question is I think that's an important piece for the residents and the fellows that are listening, because there's no reason to think that these cuts aren't going to continue. So that's a really good example of what happens in healthcare with a procedure.
Yes.
I mean, obviously you do it because you're a great doctor and you want to take great care of your patients.
Absolutely.
But it does get to the point where it's almost insulting.
Yes. Yes. And I don't think there's not I don't think it's this grand plan to do that, but it's basically legislated, right? So that's, once again, we go back to our legislation. Medicare's budget is fixed and all the dollars come out of the same pool. So if you have new procedures or new things that pay a significant amount of money before Medicare, figures it out, they see the budget and they basically have to take cuts from somewhere else in order to pay for that. So it's this constant movement, whack-a-mole, where I think that we're under, and that's exactly what it is. And I think when I give a business talk to our residents or the medical students, I mean, they're kind of surprised to hear this now. Most medical schools are at least having some education in it now, but they really don't understand why these cuts exist. So and we're not even going to get into the exorbitant cost of drugs. But there is a reason for that. It costs the companies an exorbitant amount of money to get the drugs through, and so they, but the pricing is certainly another conversation there. But once again, all that money comes out of the CMS budget, and so we're under those pressures. And in our specialty, we represent 2 to 3% of the budget. So we're a pretty small portion of that budget in our specialty. So easier to cut the ones that don't have the loudest voice.
Right. It's interesting. I went to pharmacy school before I went to medical school, and I think when I was going through pharmacy school, it took like 200 million to get a drug to market, and now almost every drug is over $1 billion to get it.
$1 billion.
Yeah.
Yes. Pretty amazing. And multiple studies required. Exactly. So that, now all the companies are still making pretty good money, so we shouldn't shed a tear for that. But
Right.
And every once in a while they get a drug like Keytruda, which cost a lot of money to bring to market, but is approved in many malignancies now, and is a 10 billion plus drug. So, but those are not common examples.
Right.
So yeah, so that CMS budget is difficult, and I think that I just read yesterday that this year was the largest number of our population, percentage of our population that reached 65. So we now are seeing a larger growth in our Medicare population more than ever. And we knew this was coming, but this year they said it's going to break all records. So, we see this huge number of people entering the Medicare system, and that is going to just further diminish reimbursement.
And and fewer physicians to see those patients.
Correct. Wait times, and I don't know what it is at LSU, but our wait times are very significant now, both in private practice and in the academic setting. So we have a medical school, multiple health systems, and lots of private groups here. And if you try to get an appointment with a urologist, a pulmonologist, a neurologist, a rheumatologist, a cardiologist, you're 4 months to 6 months now in our area.
Yeah, it's a wait time is a primary focus in our department. We're trying to different methods to see to it that patients don't have to wait
Yes.
at those kind of times. But it takes considerable effort, and the other thing is kind of dedication on the physician side to say, hey, okay, I'm going to work a little harder to get these patients in, and I think that's what we all try to do. So
We do, but of course, that I don't think we've talked about the amount of work that's generated on the back end for when we do that. I don't know about you, but typically when I leave a patient's room, I still have a lot of work to do to get that chart closed, or to get that patient to the next therapy, or to put a posting letter in for their surgery, et cetera.
absolutely. So last topic, let's talk about physician recruiting.
Mm, yeah. That's the Achilles heel of all of us, as you mentioned earlier. And let's talk about urology. 300 urologists produced a year, and that makes it incredibly difficult when 600 or 700 of them are retiring a year, and so physician recruiting is getting difficult. Many ads out, lots of locums jobs. Many hospitals, I've heard the number of 400 or more hospitals are going without urologists this year, and maybe more. And so physician recruiting has become difficult. The compensation, as a result of supply and demand, the compensation for those physicians, for the hospitals that are truly desperate to get them, is very significant. I mean, a urologist can get out and make, literally 5 times more than I started my salary at Urology of Virginia as a starting salary. And they can do that for 2 years. They can do loan forgiveness if they stay for 3 years or 4 years. So the recruiting is really become sort of MBA-esque in the contracting, where the private practitioner, maybe the 3 and 4 man group, can't recruit because of those disparities. So that is very difficult. You have to get creative. Private groups can do practice management agreements or PSA agreements, service arrangements, where they can actually say, hey, we actually both have to have a urologist to help us with call coverage, et cetera. And can we bring a physician along, and their salary can be supported within some acceptable guideline for the first couple years. That may ease the financial burden to the private practice, but you have to be very creative. You have to have a willing health system to be able to do that. When you look at even private equity groups now, they're struggling to recruit. And there's certain complexities with recruiting into private equity. And part of it is the equity that makes it more complicated. So I think recruiting in general has become incredibly difficult. We're going to see a greater shortage of physicians, both in private practice, private equity, hospital employed groups over the next 5 to 10 years. Be interested in your thoughts. Are you seeing a difficulty there in Louisiana?
So it's interesting, as we both know. I guess this would be a great time if there's any politicians or political people listening to this podcast. It'd be a great time to consider an increase in graduate medical education funding, because
Absolutely.
as stated, that level of physician, those physicians being produced is steady, and without more funding, it's not going to change. And it takes a minimum of 13 years to train a urologist, 4 years of undergrad, 4 years of medical school, 5 years of residency. So it's not like you can turn the spigot and all of a sudden produce more urologists. So I think that's one of the keys. And I know that we've all stomped the hill trying to get this message across. And I think until some of these politicians actually have access to care problems, they're going to continue to ignore it, unfortunately.
Yeah, we're seeing that. I'm actually getting calls from politicians saying, hey, I can't get into your practice. And so I think we're seeing that all across the country. You're getting those texts and those phone calls.
Yeah.
And so, but will that translate into more spots? I doubt it. I think they're obviously distracted by many other political things right now, and so I don't see it on the radar anytime soon. But as much as the AUA and LUGPA can do, we really need to lobby for more spots. In fact, in our program, we had looked at partnering with our local health systems. They were going to split a residency spot 50-50 with us. And so we still have that commitment. So I think we're going through the RRC process to get that spot now. And the hospital systems will split the cost of the FTE with us. So we're willing to do that with them.
Yeah, and that may be one of the solutions until we can get some government or some federal backing. That's a
Yes.
great way to expand the numbers.
I'm trying to contribute. My son just matched in urology, so I'm trying to help with the numbers. So
there you go. There you go. Where did he match?
Georgetown. Yeah.
Oh, awesome.
So very excited.
Any last topics that you think we should talk about or cover?
Well, no, I think this has been great. Hopefully, it's given everybody a little taste of sort of the hospital employed models versus the private practice models out there. There's pros and cons in each. I think make sure you go in eyes wide open, talk to your colleagues, and maybe this is a great thing for the AUA to have is a set of people who are willing to talk about hospital employed contracts and private practice contracts, and maybe have a group of people available so incoming residents can actually use that resource from the AUA and reach out to people and talk to them in specifics about what to look for in those particular contracts and what to expect. You hit the nail on the head earlier about expectations are key in both private practice and hospital employed relationships. You need to make sure you understand those expectations before you get in there, because that's the greatest reason for dissatisfaction in each of the employment models.
Yeah, totally agree. Well, listen, this has been great. Thank you, Dr. Fabrizio, for sharing your time and expertise with us today. Honestly, I think this is a really useful podcast, and I hope a lot of people get the message to listen to this. And thank you to our audience for joining us on the AUA Leadership and Business Podcast. Again, thank you, Dr. Fabrizio.
Michael, thank you so much. I appreciate it, Dr. Darson. Take care. Bye-bye.
All right.
Invest in your leadership and business skills at AUA 2024 with the Institute for Leadership and Business track. The ILB track features a total of 7 live courses offered from Thursday, May 2nd through Sunday, May 5th, with additional on-demand content to supplement. Whether you are starting your career, seeking career advancement or professional development, or looking to master the business challenges facing today's urology practice, the ILB track offers education to support your needs and professional growth. To accommodate the busy and robust schedule of AUA 2024 and to ensure that participants have access to all programs in the ILB track, each session will be recorded and can be accessed on demand unless otherwise noted. Visit auanet.org/AUA 2024 to learn more and add the ILB track to your annual meeting registration. See you in San Antonio.